Welcome to the second Spanish-speaking International Scleroderma Journey. We are celebrating the World Scleroderma Day. We chose these days because on June 19 of 1943, Paul Steen died, one of the most spectacular artists in the 20th century. He had scleroderma, and in his words, he gave a testimony of how the disease transformed his style from using a lot of colors to very simple traces with the increasingly thick lines. He even left a self-portrait where one can see the transformation of his face and the inner feelings that he had as a result of the consequences of the disease, excessive sensitivity, hand swelling, breathlessness, and thick skin. All of the creations in the past symptoms that we scleroderma patients know very well. However, this was one of the most fertile periods that lasted until his last days. When we selected the date of his death to celebrate World Scleroderma Day, we are honoring the artist, but most of all, the man that the adversities of the disease in Paul Klee, we see this sense of fight that many of us are using in order not to put our arms down and feel defeated. This is an invitation to reflect upon what each one of us is contributing to take care of our health with feeling with commitment and responsibility. And if I'm referring to serious information to the publications that both medicine and science publish and that should be read by their colleagues. But these are also articles that make available to patients and the general public as well. In 1921, 481 papers on scleroderma were published. To this date, 121 have been published. This is encouraging. As we have epidemiological data, there are around 2.5 million patients with scleroderma, and a high proportion of them have to wait 5 to 7 years. Odyssey. This is the time elapsed between the moment when one starts having symptoms and the moment when he or she gets the final. And the process goes as follows. The patient goes to see a doctor, and after several visits, tests, and trial and error treatments, he is referred to a different colleague who does not know what he has. Something similar happens to that other colleague and refers him to another specialist. So the pilgrimage of the patient begins from one doctor's office to another, from one test to another, from one medication to another. This is the Odyssey. And Ulysses, a mythological hero, it took him 9 years to go back home after the Trojan War. It may take that long for certain patients until they get a certain diagnosis. All of us know that the what is the wasted time, and this leads to progression of disease. We are surprised that when someone finally gets the diagnosis of scleroderma is completely worn out physically and emotionally. Let's not forget that in most of cases, that individual is underdiagnosed and poorly medicated. Is a big enemy of scleroderma because it causes irreversible damage that inevitably lead to disability and to poor or short survival. Due to this diagnostic difficulty and due to the heterogeneity of disease, scleroderma is said to be as personal and unique as a fingerprint. So not all patients have the same organ involvement or have. There is the influence of the region where we live, our environment, our dietary habits, and lifestyle. Scleroderma is a rare or infrequent disease. Its prevalence is in population. This means that there is a large proportion of the world population that might be undiagnosed at this moment. Thus, the importance of this scleroderma journey. To speak about scleroderma, it is known that it affects 4 women per male and that initial symptoms occur between ages 30 and 50. Although we know more and more cases diagnosed at ages 12 to 14, we know that most patients have skin involvement, and this is a much milder scleroderma than the one seen in adults. A few minutes ago, I spoke about informed and trained patient because of the contributions of science and medicine. I would like to mention a key contribution that is very important to cope with the disease. Patients themselves, the fundamental pillar of a patient is another patient. Committed patients with solidarity, well organized, that bet on teamwork in order to offer to their peers advice, assistance, and training that will help them become the main characters of their self care and their life. An autonomous patient who takes care of himself is someone who adheres to treatment and that only by keeping that commitment to treatment is reducing an important budget of public health. These learned skills not only reinforce their self esteem, this helps them cooperate with other organizations. Organizations grow. We see that some organizations meet other foundations and organizations located in different parts of the world working with and for patients with scleroderma. We underwent social isolation, but we were able to capitalize this and remove the borders. Monica Ramirez from the National Scleroderma Foundation in the United States, Maria Teresa Bello, and Beatriz Garcia Criado of the Spanish Association for Scleroderma, Tina Ampudia of the Mexican Association for Guidance, Support, and Fight Against Scleroderma, Marta Mayorga of the Colombian Scleroderma Association, and myself, Ana Sala of the Civil Association. 5 women with scleroderma that met again to review the success of the first of the 2021 first International Scleroderma Journey. We worked for months in order to produce a very committed agenda with themes thinking about you. This year, under the motto Scleroderma Without Borders, we opened the door Paraguay, Peru, and Venezuela. And since our heart is big, we decided to transmit this meeting with simultaneous interpretation into English to open it up to all the world. It's important for you to know that all the information that provided during this journey serves educational purposes. This is overall knowledge about the disease. So we recommend that if you have any questions, please ask your physician. You can also contact some of the patients' organizations where we can provide you guidance. It's time for us to begin as we spoke about Paul Klee and his strength. I would like to highlight one proof of this. There's a woman with whom it has been an honor to share workspaces and personal spaces. We are dedicating this meeting to Maria Teresa Bello Muñoz, president of the Spanish Scleroderma Foundation. We hug her family, the board of directors, and all of the patients in Spain. With a deep pain and feeling proud of being part of her life, we dedicate this journey to our friend Maria Teresa Bello Muñoz, who we know is going to be with us not only today in this journey, but in absolutely all the activities that we carry out. I hope you enjoy this learning experience. I give the floor to Veronica Flores Leon from Ecuador, who will be the moderator for the first presentation of this second Spanish-speaking international scleroderma journey. Thank you. Good morning, everyone. The next presentation will be delivered by a representative from Argentina. Under the title, Montoya will be introduced by Ana. Good morning, everyone, and welcome. Many, many thanks, Veronica. Dr. Sandra Fabiana Montoya is a physician specialized in rheumatology. She practices at Jose Maria Ramos Mejia Hospital in Buenos Aires, Argentina. She has the Systemic Sclerosis Clinic. She coordinates the Scleroderma Study Group of the Argentinian Society of Rheumatology. He's member of the European Scleroderma Trials and Research Group. She's the medical advisor for Esclerosalud. Dr. Sandra Fabiana Montoya, you have the floor. Go ahead. Good morning, everyone. Many, many thanks for this invitation. Thanks for this introduction, Anna. I'm going to try to answer the question, what is it that we need to know at the time of diagnosis or once we have been diagnosed? Let's get started. Let's get started with the Scleroderma is an autoimmune chronic disease characterized by immune dysfunction, vascular. All of this will result in manifestations in the skin and also in internal organs. As Anna said when she introduced this journey, this is an infrequent disease affecting mainly females ranging between 30 and 50 years of age. In 2013, new classification criteria were published. Until then, we used the 1980 criteria that when we classified a patient with systemic sclerosis, there were limitations. With these new classification criteria, we see the new disease characteristics that had not been taken into account previously, and I'm going to refer to some of them later, like capillaroscopic alterations, lung disease, Raynaud phenomenon, among others. These are classification criteria. Scleroderma, we need to ask, first of all, when does it start? The chart that I'm sharing with you is like a timeline. We see that we may start with Raynaud's phenomenon, a color change that is seen in the hands or in the feet as a result of exposure to cold. It is followed by the stage of autoimmunity where we see the production of antibodies. And then, according to the type of systemic sclerosis, we start seeing manifestations of both fibrosis that may be seen on the skin and may make the difference between either limited or diffuse compromise. And we will later explain this. And then, or one may also see vascular damage at this stage that is a sign because we know that there are vascular alteration in scleroderma and its manifestations are finger all be seen capillaroscopy. What happens with diagnosis? Anna was telling us about the diagnostic odyssey that patients go through. We see that as time goes by, and this is after the year 2000, given the time, despite all of this, the time to diagnosis is quite long. This means that it takes a long time from the beginning of disease until the disease is diagnosed. So we ask, why is it so difficult to make the diagnosis? We've said that scleroderma is an infrequent disease. It is also a heterogeneous disease. It is a disease that shares clinical aspects with other autoimmune diseases. It's likely that these are the reasons why diagnosis is so difficult. Whenever we speak about prevalence according to the geographical region, there is a study done in Argentina some time ago that reported 296 cases per million population. We also said that it is a heterogeneous disease, and this is one of the causes why diagnosis is so difficult. This means that when we define scleroderma, we refer to autoimmunity, fibrosis, and vasculopathies. So this is a disease that has several phases. Mentioned during the opening remarks. Not all patients present with the same symptoms nor have the same type of disease. On the other hand, we also said that scleroderma shares clinical aspects with other autoimmune diseases. For instance, with Raynaud phenomenon is a manifestation that is seen. If we want to see how the disease evolves, in this chart, we can see the first stage, which is the asymptomatic stage. And this is when the disease begins with the Raynaud phenomenon. Years may elapse until something else occurs. Then we have the very early phase, very early stage, where we already start seeing certain alterations that lead us to suspect that we may be in front of a patient who might develop scleroderma. Then we have the early stage, the established disease, and advanced disease. At the bottom, you see the various organ compromises. It is important to bear in mind how this evolves because without any doubt, our goal is to see the patients in the very early or early stages of disease so that we can get the best possible outcomes. For this purpose, we have the red flags. Which are the red flags of scleroderma? They are like the doors or the manifestations that we may have in front of us, a patient with scleroderma or who may develop scleroderma. We have here Raynaud, then puffy fingers who are like very swollen fingers that may appear, and fan. Fan is a lab test that helps us sort of get closer or have an idea of how close is the patient to developing scleroderma. We also use capillaroscopy. All patient with the Raynaud phenomenon is asked to undergo capillaroscopy. What is capillaroscopy? This is the capillaries using a device. These capillaries can tell us whether there is vascular damage or not. We see that the disease may start affecting the skin and inner organs. In order to determine what is the extent of the skin involvement, we have the Rodnan score. The Rodnan score is a technique that tells us how we should palpate the skin and assess the skin and determine the degree of involvement. We need to include a total of 17 areas and we score them. And this tells us physicians what is the extent of this. Divide the disease into limited or diffuse disease. Limited disease is the one that includes skin involvement from the elbows to the hands or from the knees to the feet. It may or may not involve the skin or the face. And this would be the kind of limited scleroderma with limited compromise. If compromise goes beyond the elbows and the knees, this means that we have diffuse disease. However, there are patients who do not have any skin involvement. There are patients who have systemic sclerosis, but they share characteristics of other diseases. This is what overlap syndrome. The most frequent overlap occurs with myositis, but this is also seen with rheumatoid arthritis, Sjogren syndrome, or systemic lupus erythematosus, SLE. This group of patients have more weakness, muscle atrophy, more joint compromise, and much less compromise of the skin, the lungs, or heart or cardiac compromise. Throughout time, stages of systemic sclerosis, they begin by puffy or edematous fingers that we said could be one of the red flags of the disease. But this may last from 6 months to 1 year and then is replaced or progresses to another stage with induration or fibrosis, and in the end stage, which is the final one. This skin compromise that occurs with time is going to change with time depending on or limited disease. In diffuse disease shown in blue in this chart, we see a faster progression compared to limited disease. During the first years, we have many more manifestations in inner organs in the diffuse type compared to the limited type. Once one suspects, it is mandatory to carry out an inner organ screening, trying to find whether they are compromised or not, because at times we may have an asymptomatic compromise. The lungs are particularly relevant in scleroderma because lung compromise is very important, both from the standpoint of interstitial lung disease or pulmonary hypertension. Both of them are very important conditions that represent the outcomes that we see in this condition. However, we also needed to take into account the GI organ screening because we may have a symptomatic GI screening. For instance, the esophagus is one of the most frequently affected organs. And also heart or cardiac compromise and renal compromise. When we see the timeline and the compromise of inner organs, this is what we may how we may represent this. This represents early diffuse scleroderma. Initially, we see interstitial lung disease that occurs more frequently, same for renal crisis, GI compromise, and cardiac compromise. In patients who have limited disease, and we're not showing here 5 years, we see the disease is less pronounced. So we may see that interstitial lung disease, as time goes by, it affects a large proportion of patients. The same thing can be said about GI compromise and cardiac compromise. It is seen particularly during the first 15 years, as well as renal compromise. So they both need to be considered during the first 10 years of disease. After the inner organ assessment that we mentioned, there are certain things that we need to bear in mind. First of all, avoid cold weather or use gloves. Quitting smoking is mandatory in this disease. To eat small amounts of food several times a day. When patients have a lot of symptoms, they would rather not eat because this reduces their symptoms. But in reality, this is not the right thing to do. Patients need to avoid lying down after eating to avoid their reflux. Eat moderate amounts of salt or sodium. Avoid alcohol and beverages with caffeine or carbonated beverages, and try to eat fiber containing foods. However, at certain stages of the disease, this is not recommended, but this needs to be discussed with the treating physician. Patients, it is recommended that patients begin a regular exercise maintained throughout their life, that they keep their skin hydrated, that they have proper blood pressure control. Many of these are advices that have to do with a healthy lifestyle. But beyond the organic manifestations or organ manifestations, there are additional considerations in this doctor relations, how with the various perspectives, the physician's perspective, the patient's perspective, because each one of them cares about something different. At times, each one of them is using their own language and addressing the things that they are interested in. A study showed that the biggest concern of patients is uncertainty and the lack of energy, while physicians try to focus on results of tests, comorbid conditions, and disease progression. Of course, that both of them take into account quality of life and trying to find an effective and well-tolerated treatment. That is why it is so important to get involved in the treatment decisions. First of all, because patients are the ones who are going to follow the treatment. And second, because this will lead to adherence to treatment. And this is something which is extremely important when we are measuring the outcomes. But not it doesn't all end in the doctor-patient relationship. We need to consider the place where we are, if we have proper access to healthcare, and what is our country's healthcare system like. This will also lead to differences in the outcomes. Knowledge is power, and this gives to the confidence in being able to control their disease. In closing, I would like to ask the following to reflect on. Which would be the perfect patient-doctor relationship that we should be aiming at? Which would be the perfect healthcare system so that from different places and from different associations, we could promote this kind of relations that can assist patients and can help patients with systemic sclerosis have respect for their rights. Finally, and this is a publication in which a patient with systemic sclerosis and said the following: education helped me define my disease instead of allowing the disease to define me. I believe that all education events are extremely important so that we can disseminate the disease and so that we can travel through the disease together. Of course, with the support of the medical community, but at the same time understanding clearly.
Thank you very much, Doctor, for your excellent presentation. We've received some questions via email and also through the chat. And what is the purpose of the anti-nuclear testing? As I was telling you a while ago, the anti-nuclear testing allows us so that the patient that is not diagnosed, we can see if actually there is an autoimmune component in this patient. Generally speaking, is through Raynaud. But the anti-nuclear factor, when this is reported, there is a certain pattern. that can give us an idea of those patients that, for example, potential pattern that has an anti-centromer, positive anti-centromer. It allows us to evaluate autoimmunity of the patient and then approach to the type of disease that the patient might have. At this point, the division is between limited and diffuse. The presence of positive antibodies is going to allow us in the future to divide systemic sclerosis into subtypes according to the positive antibodies. And from there, we're going to be able to see that the ones that have given positive antibodies, 70 or anti-centromer, that is positive, they're going to share certain clinical characteristics. And in fact, there are already descriptions about this. Thank you, doctor. So this means that given this, we can say that sclerodermia can be hereditary. No, sclerodermia is not hereditary. What can be inherited is a predisposition. It's not like a disease that if I have scleroderma, my children will inherit it. What can exist as a predisposition? It is not passed on, inherited. The questions that we received, that many of the patients ask, do I have to take medication for life? Will I be medicated for the rest of my life? When the questions pose these questions, sometimes I make a consideration. This has to do with the quality of life. I think that instead of focusing on how much medication we have to take, we have to focus on the quality of life, I want to have. Because medication and in nearly all of the type, there is a treatment that we have to follow. For example, the vasodilators that are that have to be taken with Raynaud, that is going to be taken for a long time because what we're going to try to do is to counteract what the disease produces.
Recording in progress.
But many times they don't have Raynaud. So in that case, we have to take medication, yes, but I believe that one must not focus on that. Rather focus on what the quality of life I want to have. And so then I'm going to pursue that. And the medication is part of the tools that I have to feel better. So this means that there's a great influence in the quality of pain that are newly diagnosed in order to decide whether they're taking medication or not for the rest of their life. Aside, the disease, well, the disease must not only be considered, considering the organ compromise. Otherwise, we would be not taking into consideration a very important component. We have done work in regards to anxiety and depression in the patients that have systemic sclerosis. And we have observed that in an important percentage, one could encounter anxiety as well as depression. So beyond the organ compromise. So the topic about quality of life also has to do with the well-being of the person. And today, in regards to the treatments, likewise, we also have many more options that not so long ago, maybe 10 or 5 years ago, in which the knowledge precisely has progressed. The treatments have advanced and so have the results. Doctor, I have another question. Why is it said that there's a higher prevalence in women than in men? You said that the prevalence is higher among women than in men. Why do we have these results? The cause of systemic sclerosis is unknown. It is known that it is more prevalent in women, as are most of the autoimmune disease, like rheumatoid arthritis or lupus. They are much more prevalent. Here comes something into play. There's a role of the hormones, very likely. but there is no explanation. Doctor, one last question that we have about the patients. Can you have sclerodermia and cancer at the same time? Is this possible? Well, in fact, throughout the course of the disease, there is a screening to see if there could be the onset of neoplastic disease. Yes, there is an association. There's a percentage of patients that can have it, and that is, it depends on the age of the patient and depending on for this association. Thank you, doctor. And maybe some final remarks that you would make about the people that have newly been diagnosed, because I understand that this is a disease that is not known very much. Many of the patients do not find the pathway. Psychological assistance is also necessary. Can you give us recommendations for the new? The important thing is for the patients that have just been diagnosed is that, first of all, they should avoid going on internet and entering the word, the disease, and then they should connect to the association of patients so that through peers, they can receive the help to transition from this stage of the diagnosis. When as a physician tries to convey certain considerations, but let's say each person sometimes doesn't have the same need of knowing it all at the very beginning. So I think that the best place in order to learn about the disease is with the doctor in office with the meetings from the different patient associations. Thank you very much, doctor. Thank you very much for your presentation. We thank Dr. Sandra Fabiana Montoya for her excellent presentation and the quality of all of the concepts. We're very convinced of that the patients and their relatives are going to feel more at ease with all of the concepts that she has conveyed. And now yield the floor with Lisbeth Ajon from Costa Rica. She will be. Thank you very much. And stay connected. Good morning. The next presentation will be given from the United Presentation and Management, and Monica Ramirez from the association will introduce Dr. Natalia Vasquez Cañizares. I yield the floor to Monica. Good morning. Dr. Natalia Vasquez Cañizares, graduate from the School of Medicine of the University of Savannah in Colombia. Currently, Dr. Natalia Vasquez Cañizares is a specialist in the area of pediatric rheumatology at the Children's Hospital of Montessori, assistant professor of the School of Medicine, Albert Einstein in Bronx, New York. Beyond her clinical approach, her research is focused on juvenile scleroderma. Her work has been published in numerous journals. 2009, she received the best scientific paper in the yearly meeting of the Alliance of Research of Arthritis and Rheumatology. Go ahead, doctor. Thank you very much. Can you please share my slides? All right, perfect. Thank you very much for this introduction. I am very excited and I'm very thankful for this invitation. This is something I have always dreamed. I've always wanted to have a representation from the Hispanics in the United States. And I wanted to give the opportunity of the Spanish-speaking patients, that is something that is very important and it is very close to my heart. And scleroderma, in general term, is very similar to the one on adults. So there are certain differences in terms of the onset and management. I will try to summarize clearly. This is a presentation that I could give in 5 hours. I will try to summarize and I will only do it in 20 or 30 minutes. These are my disclosures. I simply want to say that I receive financing for research on juvenile. The table of content, I will summarize the disease, how it happens, what are the types, how it is diagnosed, and in general, what are the problems that could arise, and what is the management and the prognosis. And as my colleague has said, the definition, well, I like to understand etymology of the word so that the patients then can have this understanding as well, because many times we use medical terminology that is different. Heart and derma means skin. So scleroderma is a disease that is manifested by a hardened skin in children, particularly it is in children under age 18. It's an autoimmune disease itself. It happens from within your own body. And this is a response that is incorrectly targeted from the immune system towards your own body. It primarily affects the skin, like in localized scleroderma or morphea, but it can affect other organs like in systemic sclerosis. It's very important that the two types of diseases are different entities and they do not become into systemic sclerosis. It's difficult for one to lead to another. How does it happen? The truth, even the scientists and the physicians do not know how this happens. It is important that for the parents or the patients, they do not know. We have certain ideas of what are the processes underlying. My colleague has explained there's a genetic predisposition. This means that there is family history, or there are certain genes in the family that predispose to the development of autoimmune diseases in general, and then that we have not been able to identify, but it could be that very likely in the pediatric age, there could be infections from the immune disease. At this age, maybe an infectious trigger a response of the deregulation of the immune system, producing an exaggerated inflammation. This is the way it works. This is the immunological system. Normally, there are cells that we call lymphocytes that produce a series of antibodies. These would be these figures in the shape of a Y. They would be like the soldiers. And these cells produce these antibodies. They identify the viruses or particles. They produce inflammation, and then they try to control this infectious process. In autoimmune disease, the same response occurs with the difference that these cells do cells from your own body, and these antibodies then attack and produce inflammation. And the second important component is that the immune system has the capacity of controlling and telling when to stop this inflammation. When the risk has been controlled, then the immune system shuts down and it starts producing inflammation. No recognition of the cells that are being damaged, but as well the immune system does not have the capacity of shutting down. So this is an inflammation that it's chronic and constant. There are three important factors my colleague has already mentioned, which are the ones that we believe produce all of the symptoms. We do not know what happens first, or we know that there's an interaction among the three that perpetuates the factors. And one is inflammation. We have to understand that the inflammatory signs are pain, heat, reddening, inflammation, loss of function, and this easily can be identified externally, for example, when there's arthritis. But the same thing could happen in the internal organs internally. That is when, and the patients just feel ill, They have fever, pain, fatigue, and sometimes it's difficult to explain, and the people do not perceive this externally. The second thing is vasculopathy. This is malfunctioning of the blood vessel. There's tightening, stricture of the vessels. There's a reduction of the blood flow with a reduction of the oxygen to the tissue that perpetuates, once again, inflammatory state, and that leads to fibrosis. Fibrosis is a medical word that we use to indicate the repair process of the tissue, but in the case of sclerodermia, this is an abnormal process that induces to the process that is called an abnormal scarring. This is a disease that is very heterogeneous. A simplified classification, then the whole array opens it, and more that is why it's so difficult to manage and diagnose. It's difficult to do clinical testing. The general term that we rheumatologists use, scleroderma, that it covers all of the types of scleroderma. There are two main ones: localized, that is also called morphea, or the systemic sclerosis. The localized scleroderma, generally speaking, is have a defined shape. Systemic compromises the skin in a more diffuse ways. There is no limit of the identification with a normal and affected skin. There's no distinction in morphea. There are 5 subtypes depending on the type of lesions. There's the defines the severity, and systemic, it depends on the amount of the skin that is compromised. Like my colleague has already commented, something very important to mention, that there are differences between juvenile and adult. In the case of the localized form among children, the most common one is lineal, and the mixed, and in adult, the most common is circumscribed. And this is very important because the management is going to be very different depending on the age. And that is when there can be certain complications in the management for children. For example, if a child is treated as an adult, or and in terms of the systemic, the most common one among children is diffuse and overlapping, whereas in adults, it's what you would see is the limited form. Usually, the disease affects more girls in a ratio of 1 to 3 because of the localized form, and 4 to 1 for the systemic sclerosis. Average age in the first decade of life, generally speaking, 6 to 9 for morphea, and 8 to 11 in systemic sclerosis. And kids are older, when they present systemic, it can affect any race. It has been described more frequently in Caucasians. And my personal opinion is because epidemiological studies have not included other races in the trials. This is a bias more than a characterization of the disease itself. Just to give you an idea of how rare this disease is, only speaking about localized scleroderma, it's more common, that is more common than the systemic. This type of disease is 70 times less common than idiopathic juvenile. Having knowing that juvenile arthritis is rare, we're speaking here about a disease that is extremely rare in the general population. It's common than lupus, but in terms of localized sclerodermia than juvenile systemic sclerosis. Once again, this is a condition that we do not see frequently. How is it diagnosed? The diagnosis is clinical. This means that it's based on the symptoms of the patient and the evaluation done by physicians or rheumatologists, supported by imaging and lab testing. That is when we have blood work done to identify the antibodies or images that diagnose, for example, in an echo or in the internal organs. Very important. The skin biopsy is not always necessary, and in most of the cases, we do not require it for the treatment, for the diagnosis. Let's speak about localized sclerodermia and how it manifests. It starts with changes in the skin that occur throughout several months, and that is why it's not noticed. Many times it is diagnosed as trauma or lesion or an allergic process. and then it is not noticed. It goes unperceived for several months. They come to the rheumatologist when they already have permanent damage. Limited to one side, it can affect both sides, and lesions have different shapes, colors, size, textures. The patients indicate that the skin can itch or have a funny sensation. The colors can help us identify if it's active or inactive. Generally speaking, inactive lesions, they have inflammation, as I had already told you. They can have reddening, and the spectrum of the reddening can change from clear pink to purple, but it can also be a yellowish color or whitish color deposited in the central part of the lesion. This indicates then an increase in the collagen deposition and loss of the pigmentation if this the inactive form. And it is very important for the patients that have different race from the Caucasian. The diagnosis is even more complicated because the physicians do not have the training for this in the African races, for example. All right, let's try to speak about each one of the types. Morphea, I won't review them all because of time constraints. The most frequent ones: localized lineal morphea, which has an incidence of 40 to 60% in children, because they can affect the articulations, compromise the growth. They can be observed in the face, like in this case, in the coop, as if a sable coop. That is what the name means. And it's very important that this type of lesion can affect deep structures like subcutaneous tissue, the fatty tissue, bones. And that is why it produces permanent damage, severe disability if they are not treated early on. Most importantly, or more severe when it is located in the brain or the teeth or the cavity, the oral cavity. Circumscribed morphea represents 15 to 30% of the pediatric population. These are the type of more common lesions in adults, and it can be superficial when it only affects the superficial areas of the skin, or it can be deep when it affects internal structures like the subcutaneous fat. I will emphasize once again, sometimes these lesions can be treated with ointments, with creams, if they are only affecting the skin superficially, very rarely seen in pediatric patients. That is why we always indicate treatment that is systemic. Compared to the adults, most of them can only be treated with cream. The generalized morphea that is present in children, it's unilateral, and it affects more than two parts of the body, the extremity or the trunk, and more than 3 centimeters. Uh, and as you can see, this is the manifestation. These are unilateral. What other problems could occur? In localized sclerodermia, as I have said, it can affect other structures outside the skin. This is what we mean by extracutaneous. What can they be? The fat, the muscles, joints, tendon, nerves, or bones. Different from the systemic, the internal organs are rarely severely affected, and these patients do not have vasculopathy as in the Raynaud's phenomena, but we believe that at a microscopic level, there's alteration of the vessel, because in biopsies, we have identified that the anatomy of the vessels is not normal, but it's not per se a Raynaud's. The extracutaneous disease, different from adults, occurs very frequently from 22 to 75%, and it is the main cause for disability. In children, tissue generally are close to the skin that has been affected, but in 25% of the cases, it can be distant from the lesion. What type of extracutaneous are we referring? Arthritis, the joints can be compromised, it's rigid pain, there's a reduction of the movement, loss of function, there can be affectation of the muscles. There can be myositis and inflammation of the muscles. There can be pain and weakness. The limb can seem smaller. And when it affects the head uh, of the bone, the legs can be shorter in terms of length and circumference, and there in the head there can be neurological, dental, or vision problems. Now, when let's speak about systemic sclerosis. Both systems or main manifestations are Raynaud and skin changes. They occur practically in almost all of the patients. Between 74% to 100% Raynaud can occur up to 5 years before the development of cutaneous disease. As my colleague has commented, the diagnosis is difficult. Raynaud is characterized by sensitivity to cold. There's an exaggerated response of the blood vessels. They're closed. There's a reduction of the to be pale or bluish. Skin changes, like my colleague has commented, go from puffiness, swelling, or as what we say, puffy hands, or they're patched, let's say, and through the years and months, there is a hardening and it causes atrophy. That is when the tissue becomes thin and attaches to the internal structures. When there's an affectation on the face, expressions are lost. As you can see in the case of this child that has systemic sclerosis, there's thinning, opening the mouth, and then this can affect eating. Other problems as well of systemic sclerosis, they can be musculoskeletal. This is the percentage. The frequency varies between adults and children. Musculoskeletal problems, arthritis, myositis are much more frequent among children, and this is a cause of pain and disability. Gastrointestinal problems are very important. The children are growing, the children have delayed or stagnated growth, and gastrointestinal problems can be observed up to 74%. Lung disease and cardiac disease as well are less frequent in comparison to adults, but particularly pulmonary disease can produce frequent disability. Other organs as well compared to the adults, fortunately speaking, very renal crisis or neurological problems among children. How is juvenile sclerodermia treated? Nowadays, there is no cure, but we have treatments or medications that can control the symptoms or avoid the progression of the disease. As we have already said, this is a heterogeneous. The treatment varies from patient to patient, and it's individualized according to the needs of each child, depending on the type of sclerodermia, the affectation, where the lesions are located, the depth of the lesions, if there is extracutaneous disease, what internal organs are affected, the duration of the disease that indicate how severe or aggressive we should start the treatment, and how much does it impact the quality of life. In the case of juvenile sclerodermia, I do an emphasis that we should always, the management is very difficult, different from adults, and in morphea or localized, there's always an indication of systemic treatment. And because of the frequency of extracutaneous disease, it's not convenient that it should be just handled by dermatologists. They do not have the appropriate treatment to detect arthritis and other extracutaneous problems. The objectives of the treatment: reduce inflammation, the pain, functional deterioration, prevent or minimize permanent damage, allow for normal growth, maintaining quality of life. Well, with this, I will show you this chart again. This helps us to guide the treatment. So we are going to provide treatment for each one of these factors. In terms of the inflammation, we need systemic immunosuppressors to control the inflammation, to reduce in controlling inflammation, particularly in localized. There are consistent clinical manifestation. Methotrexate in particular has an effectiveness that is higher to control inflammation, and I'm speaking specifically of morphea. And these treatments are required for most of the children. They can be oral or injections. The most used corticosteroid, methotrexate, mycophenolate, mofetil. We're now using new medications like the biologicals, tocilizumab, rituximab, that have shown effectiveness in adults for pulmonary disease as well. And in terms of vasculopathy, once again, the purpose of the treatment is to open the blood vessels so that there's flow and the oxygen can reach the tissue. The medication is used to open them. We use these medications that I have listed. First line, dipine, amlodipine, sildenafil. In other severe cases, in some patients, you can also use antiplatelet medications, clumps, and that also helps for the better flow of blood. And the effect, unfortunately, has not been clearly demonstrated. In terms of fibrosis, unfortunately, this is the area where we need a lot of research, because this is the manifestation that produces permanent changes and more disability. We've started to make progress. There is a medication that has been approved to treat fibrosis in pulmonary disease in the patients that have systemic sclerosis, nintedanib. There are others in the pipeline, unfortunately, because the pediatric population requires more, has more problems. There are more ethical considerations for the research. We do not have trials in regards for treatment to control fibrosis in children, and nowadays they have not been used. Supplementary therapy, they're very important as well. And I say supplementary because, once again, I said topical agents must not be the primary. There must be complementary. There can also be uh, UV treatment for adults, and dermatologists use it. We have a little bit of concern for children because exposure to UV rays for extended periods of time can increase the risk of skin cancer. Occupational therapy and physical therapy to recover the function, to strengthen the muscles, the joints. Nutrition is super important. We could consider corrective surgery, but normally speaking, we do not recommend surgery as long as the disease is still active. We recommend 1 or 2 years of inactivity so that we would consider corrective surgery, and support in school and mental support is important. What is the prognosis of juvenile scleroderma? In terms of localized, the prognosis has improved significantly in the last 20 years from the introduction of methotrexate as the standard treatment. And nowadays, we have made more progress in how to evaluate this disease and in a more appropriate way. And that this has improved in the prognosis. Most of the children that require treatment have a favorable outcome. 1/4 of the patients can have a relapse after they discontinue treatment. This requires more studies to identify the risk of these type of patients that have the risk of recurrence. In terms of juvenile systemic scleroderma, this is a chronic condition. It's for life. Morbidity and mortality is much less than in adults. There's less frequency and severity of the compromise of internal organs. There is disability because of the joints and the Raynaud phenomena, and pulmonary disease, which is common. What causes a greater impact in quality of life is digestive problems and malnutrition in children that are growing. Obviously speaking, this is extremely important to consider. Thank you very much for your attention. And I will now take questions.
Many, many thanks, doctor. I'm going to read the questions that we have received via email and via the chat. First, what is the specialist that should see my daughter to reduce the spots of localized scleroderma or morphea? To correct sort of permanent changes, as I said, dermatologists may assist us with certain topical treatments, but if there is the need for surgical correction, you may see a plastic surgeon. But once again, this has to be done very carefully. And together with a rheumatologist, you need to make sure the disease is not active. At times, it is difficult to go back to the normal skin color after there has been skin decoloration. This may be permanent. That's why it's so important to on. Second question, will scleroderma affect my son's daily life? Well, the purpose is that that we as rheumatologists can support these patients so that they can have a normal development, go to school without any pain or without any problems. But there are permanent changes. This is super important. That's why we need to educate so that they can diagnose the disease early on. this journey serves this purpose. This is an opportunity to approach the patients. It's We want parents to educate their child as possible so that they are aware of the disease, and this may lead to early diagnosis. We as rheumatologists should assist children to have proper growth and avoid permanent complications. Should I make any arrangements with my daughter's school because of the drugs that she needs to take to manage scleroderma? This is a super important question. This is something that we pediatricians bear in mind. This may vary from country to country. In the US, by law, children with a disability need to receive assistance at school. There are specific forms where we physicians write down what are the conditions so that they can get assistance. For instance, a cushioning for the elbows, a special desk of carrying heavy objects so that all materials are placed at the school so that they don't have to carry. At times, the fact that they need to miss school days because they have to go to the doctor. All of this management should be part of treatment, and this should come from the pediatric rheumatologist that knows how to communicate with the school according to the child's needs. What are the precautions I should take before I vaccinate my child? Well, usually there are no precautions to follow. The only vaccines, if the children is taking immunosuppressor, are those made with live organisms. That is to say, varicella or chicken pox, measles, rubella, all of these in children who are receiving immunosuppression. But most of the vaccines have no contraindication. In fact, we recommend the vaccines because it is very important to avoid this kind of infections. What kind of damage may morphea cause in the eyes, and how can this be detected in a timely? It may be asymptomatic. At times, children have no symptoms. And this is when pediatric rheumatologists should be involved in treatment because they need to order periodically the ophthalmologic exam. This is at least once a year. But if there are symptoms, this may be uveitis, that is to say, inflammation of the inner eye, and as changes in vision, eye reddening, photosensitivity. So these changes may occur, but this is usually symptomatic. Another problem is when there is involvement of the eye structure. If there is an eyelid or palpebral lesion, there may be reduction in the eye size, overgrowth of the eyebrows or eyelashes. In these cases, the rheumatologist will tell you who is the specialist that you should see. Another question, what are the causes of scleroderma in neonates? A difficult is the cause for scleroderma, but when we see it at an early age, we think that there is sort of transmission of mother cells that go through the placenta, and they go inside the baby's tissues when they are growing. The baby may recognize those mother cells are as foreign, and this may be the cause of the disease in a neonate. But these are extremely rare cases, but they do occur. Another question. Can you predict disease progression with capillaroscopy? In the case of systemic sclerosis, it may help. Yes, it may help in diagnosis. There may be changes along the different stages of disease. There may be changes in the blood vessels. In other diseases like dermatomyositis, there may be regression of those abnormalities, and this is correlated with disease activity. In scleroderma, it is not very clear whether that helps monitor the disease activity as such, but it is a clear abnormality. At times, it is detected very early on, and changes may be reversible. So capillaroscopy may help us monitor or follow the disease, but it's difficult to know whether those changes are indicative only of disease progression or not. It's part of it, but I would say that that's not the only thing that we need to look at. Another question, I would like to know what is your approach to linear scleroderma. My daughter was recommended in 2019, and she's on mycophenolate mofetil right now. The infantile arthritis partnership in Latin America, we have made important advances regarding the treatment approach. Standard treatment is methotrexate. It is the only medication that has been used in clinical trials and that has proven effectiveness. Of course, it is not always well tolerated, and that's why when we turn to mycophenolate and other drugs. We are conducting a trial comparing mycophenolate with methotrexate, and the activity is the same, but we are only starting the trial. My approach is that all patients with linear disease require systemic treatment. We begin with methotrexate and we combine with corticosteroids, or at times they are not necessary, but that would be my overall approach. What is the prognosis and treatment for a 9-month baby who was born with localized scleroderma that involves 80% of the body, the head, the chest, and the extremities? This sounds like a complicated kitten. Is that we are able to identify whether there are any new lesions and that early intervention takes place. At an early age, obviously, the prognosis may be more complex. Don't mean that the prognosis is poor, but if you provide proper treatment, then you may be able to control the disease and stop new lesions from appearing. I suggest that you go with a rheumatologist who has experience in managing these cases. If not, in the United States, we can give you recommendations or provide guidance to rheumatologists in your country. Thank you. Thank you very much, Dr. Natalia Vasquez. Thanks for your presentation. I'm sure that you've additions. Allow me to give the floor to Elizabeth Gallardo Andrade from Peru, who will moderate the next presentation, the third one. Good morning. Our next presentation will be delivered by Colombia on the comprehensive rehabilitation and quality of life of patients with scleroderma. Marta Mayorga from the Colombian Association of Scleroderma will introduce Dr. Sandra Castellar Leones. So Martha, you have the floor to introduce our next speaker. Good morning. Dr. Sandra Castellar Leones specializes in physical medicine and rehabilitation. She's doing a master's degree in disability. She's professor of physical medicine and rehabilitation at the University of Columbia. She works as a physical therapist at Roosevelt Institute and at the National University in Columbia. Good morning, everyone. Thanks, Martha, for this introduction. I would like to thank the organizers of this meeting. Thank you for this invitation. It's a pleasure for me to participate with you. This is a very interesting topic. Comprehensive rehab and quality of life of patients with scleroderma. As the previous doctor said, scleroderma warrants multidisciplinary approach that involves not only the approved medications that we use to treat the disease, but other complementary or supplementary measures that help the patient do well. Some of the most important complementary measures include rehabilitation. Everyone speaks about rehabilitation nowadays and quality of life. However, many people do not really and deeply understand what these terms mean. Rehabilitation consists of a group of professional measures, but also educational and social measures intended to restore to the individual the greatest possible functional capability and independence. When people think about rehabilitation, they think that it's only physical therapy, but this is not the case. Rehabilitation is part of the beyond this. It also includes educational activities like this journey, as well as the social measures implemented so that the patient can be part of society. Quality of life is the perception that an individual has of his own well-being. It is determined by the person's cultural context, the value system that the person has, their goals, expectations, standards, and concerns they have throughout their life. So that's why quality of life is something that is quite subjective and varies from person to person. For someone, maybe quality of life may represent pain management only. For someone else, quality of life may be being able to work. For someone else, it may be studying. But for someone else, quality of life may mean not having to worry about certain tasks because they have a limiting disability. So quality of life is different for each individual. In a multidimensional concept, it refers not only to the physical aspects of the body, it also considers emotions and social well-being. So rehabilitation and quality of life are real terms that have a marked impact on individuals, whether individuals have a disease or not. What does rehabilitation involve? Well, it also includes several dimensions. All those of us who are rehabilitation professionals and those of us who see patients with scleroderma, we have physicians specializing in physical or physical therapies. We are the physicians that lead the rehabilitation team. We focus on the various functional areas, the physical one, occupational, emotional, and independence. So a specialist in physical medicine and rehabilitation is a professional working by organizing and integrating a team so that the patient is the best, does his best possible. There are physical therapists, occupational therapists, psychologists, neuropsychologists, or those dedicated to audiology, specific interventions in a patient based on their training. What are the recommended rehabilitation activities for patients with scleroderma? Well, of course, exercise therapy. Physical therapists are health professionals, and in the case of scleroderma patients, they try to carry out activities during the session to maintain joint ranges of motion. Because, as the two previous speakers said, patients with scleroderma have the trend to have a joint deformity because of the stiffening or of the skin. We physical therapists need to keep joints mobile so that they do not get stuck. This is achieved through mobility and stretching. Like in the patient I'm showing you in the video, this is a patient with scleroderma, and we are teaching him to do stretching of the phalanges so that he can maintain range of motion. Additionally, muscle strengthening exercises are indicated. As the doctors, as the previous speaker said, in patients with scleroderma, muscles may be affected. Most patients are, in most patients, we try to indicate exercises with weight or with special devices that are placed on their legs and arms. So we try to promote joint mobility and strengthening. We also, under physical therapy, we have a balance and gait problems. Patients with scleroderma may feel instability, loss of balance, or they may have frequent falls. It may be difficult for them to work on uneven grounds, and at times they need support. Physical therapists try to improve this with balance programs so that patients can feel more stable, prevent falls, so that they have a safe and secure gait. What are other physical therapy activities? Well, all exercises of ventilatory mechanics and aerobic exercise. Due to the sedentary lifestyle resulting from chronic pain and motion limitations, patients may lose part of their pulmonary reserve. At times, patients have to climb 3 stories to get home, and they can hardly breathe after climbing 3 stories. So we also include breathing related activities. We try to strengthen ventilatory and respiratory muscles, and we indicate a role with the have muscle and joint health, but also ventilatory or lung health. In patients with scleroderma, it is important to manage pain using physical media. Pain is subsides as the disease becomes inactive, and this is achieved with baseline treatment. But to use as well as physical therapy, for instance, the use of paraffin, massage, physical media like heat, cold. This produces a joint sedation and improves stiffness and therefore relieves pain. In physical therapy, we use another non-conventional modality, which is hydrotherapy. Patients with scleroderma that use hydrotherapy feel very well because when one is in the water, the body weighs less, there is less gravity, and patients may carry out muscular exercises with more easily. So when one inside in the water, it's much easier to mobilize. So this becomes easier for the patients, and inside the water, one may activate certain muscle groups that we cannot activate when we are outside the water. And hydrotherapy has sedative purposes. So hydrotherapy is one of our rehabilitation interventions in patients with scleroderma, and they usually do quite good. During hydrotherapy, we ask the patients to undertake swimming lessons or to go swimming independently so that they can maintain the benefits of hydrotherapy. There are many, many activities that we may indicate as part of physical therapy, both during our sessions or that we may recommend for patients to do independently at home. Occupational therapy in patients with scleroderma can comb their hair, brush their teeth, write, button up, unbutton, and so that they can carry out self-care activities without the need for assistance from someone else. These are very important activities for human beings. And brushing their teeth independently is very important. This is the purpose of occupational therapy, to have patients be able to undertake these daily life activities. At times, certain devices need to be adapted. For instance, we can have a thicker handle of the hairbrush. We may change the shape of a spoon, use handles so that the patient can better grab the spoon, or special devices so that patients can put on their shoes, devices for buttoning or unbuttoning. There are many devices that we may use on a daily basis so that patients can be independent in carrying out their self-care activities, so that patients can dress by themselves, put on their jacket, and so on. This is the goals of occupational therapy. Phonoaudiology. This is a profession involving patients who have scleroderma, as there are alterations in the extremities, they occur in the face. So patients with scleroderma have decreased face mobility, and this has repercussions on swallowing. So phonoaudiology is in charge of all of these activities that improve face mobility, orolingual facial practice to improve or maintain proper swallowing in a safe way. Psychology is another profession included in rehabilitation. We try to handle all of the emotional aspects of patients that may be affected in the patient and their family. Disease does not only affect one individual, the person who has the disease. A disease involves the entire family, the mother, the father, the siblings, have any, because they produce a big emotional impact, particularly when disease causes functional limitations or disability. Psychological assistance is useful for patients to express their emotions. It's okay to cry, that's not bad. This is the way in which we can let out our emotions. Feel worried. People should express everything that they feel. They should not keep it within themselves. However, we psychologically we can assist them so that not everything is negative, so that and help patients overcome their disease. Psychology approaches not only the patient but the entire family. In fact, there are diseases that may cause a family disruption because of the emotional impacts of the patient. But psychology provides assistance on this so that people who have the disease can cope with it. Under psychology, we also include a life project. If a child, a teenager, or an adult have scleroderma, well, that doesn't mean their life has ended. No, they may live for many, many years. Someone with disease or a person with a disease continues to be a person, and life does not end with a diagnosis. The fact that a teenager is diagnosed with scleroderma does not mean that he cannot go to college or cannot take the trip that he wanted to. So in psychology, we make sure that life approaches can be possible in the long run. If someone is taking medications but is doing poorly emotionally, well, means this is not working. So mental health is essential, and that's why we include psychology as part of rehabilitation. Wheelchairs are devices that are part of rehabilitation. As physiatrists uh, working already for 10 years, this is one wheelchairs are one of the devices to use. I have children, I am a mother, and I know what is the impact that this may cause. It's not nice to see someone who has always walked, have the disease, that wheelchairs do not represent a barrier. No, it's the opposite. These are devices that are there. These are medical devices that help patients move, be transferred from one place to another. But most of all, they help us not have patients locked up at home or being bedridden. Let's say that there is a family meeting and a patient cannot go because there's a long distance to go there. And because that person does not have a wheelchair, he or she cannot attend that family meeting that would be so pleasant. So there are devices that we have, for instance, a wheelchair when there is markedly compromised mobility. And the purpose is to help patients continue to be sociable, independent, and to maintain inclusion as well. An important point of rehabilitation that I want to mention to close is education. Education of the patient and their family. The previous speaker mentioned this. Education represents a fundamental pillar in medical and rehabilitation treatment. If I'm can help or can make a patient understand the disease, the treatment, the exercise plan, and the reason for all of these treatments, and the patient understands that this is a lifelong treatment, this will have an important impact on their quality of life. Patients will not attend physical therapy, occupational therapy, phonoaudiology, or psychology forever. If someone is going to live 30 or 40 years with scleroderma, they're not going to go to therapy, to occupational therapy or physical therapy permanently. That makes no sense. Someone cannot rely only on rehabilitation. At times, the patient does not have someone to bring them or take them to rehabilitation. That's why we prescribe exercises and we want patients to understand the disease, what they can do, what they cannot do, so that they can undertake the treatment or the exercises on a daily basis without the need to go to the hospital. And what we want to achieve is adherence to treatment. So that's why education of the patient and the family is so important. We also need to educate health professionals on the management of diseases. From their perspective, can undertake, including physical therapy, occupational therapy, exercise, phonoaudiology, education, and even social activities. Part of rehabilitation is to understand that there are barriers in our setting that at times we need to go out of the elevator because someone that has a special requirement needs us to move. All of this is part of rehabilitation. Conditions like this one. I will leave you my email in case any of you have any questions that are not answered right now. Please feel free to write me. Thank you very much for an excellent presentation. Thank you, Sandra. I'm going to read the questions that we have received. Someone says, I have a lot of stiffness in my hands, particularly the phalanges. What kind of exercise can you recommend? And how can I relieve pain? Stretching always. As I said before, the disease causes stiffness and puffiness, and as a result of this, the elbows, the wrist. So stretching exercises should be done absolutely on a daily basis. We need to learn how to do them in order to maintain mobility, open, close, stretch, like the patient in the video that I shared with you. Paraffin may be used. In fact, paraffin is one of the physical media that we use to relieve pain and to relieve stiffness. But since we don't go to physical therapy every day, to maintain mobility, we need to do stretching and mobility exercises. Thank you. For the oxygen, because I have a pulmonary hypertension resulting from scleroderma. What can you recommend? Well, 3 years without exercising, this is not very good. You should try to exercise. You may be under oxygen and have CPAP, BPAP, but those are devices are not contraindications for exercises. They make it a bit more difficult, but this is not impossible. I recommend that they exercise at home if they can walk together with their device. If they have a bicycle, stationary bicycle, they can use it inside the home. So may use the treadmill or hand bicycle cycle ergometer that help maintain mobility as well as aerobic capacity. She has not exercised after 3 years. I would recommend that she starts exercise little by little, going from mild to moderate intensity. Thank you. Next question. I have scleroderma and fibromyalgia. What exercises do you recommend that I do at home? I'm sure you have a lot of pain because both diseases cause exercises at home would be aerobic exercise. That may be walking out in the park or at home, stationary bicycle. And hydrotherapy is very good. If you can go to a swimming pool and walk inside the swimming pool, that would be very good. Hydrotherapy is recommended for both conditions. There are patient intervention that has been proven for different conditions. It is more fun It's appropriate for children, and this allows to do aerobic and muscular exercises. Does exercise improve or increase muscle mass? Yes, but not all types of exercise. You need strengthening exercises. Walking does not really increase your muscle mass, but strengthening exercises with a band or TheraBand, those kind of exercises increase the muscle mass. What exercises prevent loss of mobility in finger joints? All activities that you can carry out on a daily basis that do not mean that patient is inactive are essential. As easy are buttoning, unbuttoning, opening or closing a zipper, writing, combing your hair, brushing your teeth. All of these are activities that maintain hand activity. I'm saying this because it happens that moms, dads, or the children of the parents with these limitations try to do everything for the patient. And no, that should be avoided. People should try to carry out their daily life activities to the extent possible, like combing your hair, brushing your teeth, writing, buttoning, unbuttoning, opening up the zipper, and working with dough. In Colombia, you clean rice, like you degrain rice. These kind of activities are quite easy to do on a daily basis, and they are quite useful for these patients. Someone says, if I'm a physical educator and I work for more than 8 hours a day with physical activity under the sun, 2 weeks ago I was diagnosed with progressive systemic sclerosis. Should I switch to a different occupation or job or career? Well, it's difficult to say. Well, it's not easy to switch to a different profession study. I think that we have to see what the society is giving to people and not what people are giving to society. What should happen here is that she should be able to continue under medical work recommendations, allowing her to switch to a different job, or we should be able to find a strategy so that that individual can continue to work in as part of activities that are easier or with assistance. We need to reduce her work hours and avoid sun exposure. She should not switch to a different profession. We should be the ones making the changes so that there is inclusion, so that she continue to exercise or practice her own profession, but without the need of experiencing any harm. Do you recommend aerobic or exercise, yoga or others? Well, that kind of exercises like yoga, those exercises, we don't have strong scientific evidence for them. However, there is no real contraindication for them. They work for certain patients. For some patients, meditation. What we say is that if it works for the patient, they can do them. But it's different from us saying that there's strong evidence for that or that's going to relieve your symptoms. We need to be very, very careful with certain poses and with jumping, and we needed to monitor bone health. Many of the drugs that are used may cause loss of calcium in the bone. And there are certain poses that are mechanically complicated and may lead to a fracture. So there is not absolute contraindication for this, but we need to control if there are no problems or no risk, and that works for the patient, that's possible. Dr. Sandra Castelar Leones, thank you for your participation. We understand the importance of having an exercise plan in our daily life. I give the floor to Carmen Daniela Gonzalez from Chile, who will moderate the next presentation.
Good afternoon. Good afternoon. The next presentation is from Spain. Sclerodermia and tiredness when the batteries never seems to be charged. Or do the introduction of our speaker, Dr. Paloma Garcia de la to Beatriz. Good afternoon. Good afternoon, good morning, depending on the country where you're at, where you're following our event. Dr. Paloma Garcia de la Peña, rheumatologist, a professor at the University of Alfonso X el Sabio from the Immune Institute, General Secretary of the Spanish Association of Rheumatology. Her fields of interest, sclerodermia, uh, pathology of autoimmune disease. The floor is yours, doctor. Well, the first thing, um, thank you very much for inviting me to participate in this event. For me, it's an honor to be here with you. And well, good afternoon to those of you that are in Spain, and good morning to the people on the other side of the ocean. Let's see if I can see my presentation. I don't see it. Can you see it? Can you see it now? Can you see it? I can't see it. I would like to dedicate this presentation to Teresa Bello, the president of the Association of her family, and to all of the people that love her. This is for you, Teresa. All right. As I have already been introduced, this presentation is going to be on tiredness or fatigue. When I make an effort and I cross streets and and I talk to people, maybe if, I ask them, what is it? Some people don't sleep well. They're sleepy, people that do a lot of exercise and then they feel tired. Other people say that after having worked very hard and after being on the computer all day and they're tired. And other people would say, well, when I don't eat, I am very tired. I can't bear it. I feel weak. But for another part of the population, for those people that have a chronic disease, particularly tiredness is a word that if we ask to a physician, a doctor, what tiredness is in medical terms, we know that we use words, different words for everything. So in this case, medically, it's called asthenia. So what is asthenia? Asthenia is that feeling of lack of energy or vitality that is sustained throughout time, that appears when the person is at rest, and it also increases the more physical activity the person does. On the other hand, it is a very frequent symptom. It can be unleashed or triggered by many diseases, not only scleroderma. When asthenia is lasting and intense, it corresponds to the existence of a disease that is relevant. So physicians, we have to be observant and detect it, but we also have to do a differential diagnosis of other things that the patient is going to identify and refer as being tired, but it is not this tiredness that we understand that as asthenia. It's a muscle weakness problem that the muscle does not respond because I've lost strength or I'm fatigued. My muscle, I use my muscle, and to the extent I use it, the muscle becomes tired. So then the doctor has the obligation of differentiating, distinguishing what tiredness is. So if I ask you, or if I ask you what tiredness is, you will refer different things. You will say that's a symptom that accompanies you on your day to day. You can also tell me that's a symptom that sometimes affects your mood. It sometimes occasionally limits your work life. And on other cases, well, I feel tired. For example, methotrexate. And it's also a symptom that is not observed. Sometimes there's a lack of understanding by the people around. And it also limits personal life and social life with your best friends in the world. Sometimes if you're really tired, worn out, you don't feel like going out with friends. About being tired to understand the type of tiredness these patients have if they have scleroderma. Duration. This is a symptom that can appear even before the diagnosis, particularly in the diffuse forms that have affectations on the skin. It can be among the first symptoms. It's different also from something that appears suddenly, from that progressively also affect, could be a tiredness time. On the other hand, then we have to consider intensity. Can be mild, moderate, or intense. Debilitating. Does not allow me to do my normal life. It can be continuous throughout the day. It can be intermittent as well. So 2 weeks tired, and then I get better, then I get tired again, and then it changes in the day. People wake up, they're very tired from the moment they get up, and then it improves once again in the night. They feel tired. So not all of the forms are the same. And something very important, if it is accompanied by symptoms, by other symptoms, it's not the same thing. If it has fever, or if it's accompanied by a loss of appetite, what we call anorexia, or if it's accompanied with sweating, if it's accompanied by weight loss. But these symptoms help us to understand what type of tiredness the person has. What does it cause? Well, on the one hand, I just said disease causes it. We can say that it can appear at the beginning of the disease, it can appear in an acute form, and it can be have a chronic onset, but it can also be due to other diseases. The patient sometimes has other problems that have already been mentioned by the colleagues here. For example, depression, that can have a tiredness. Medication also can cause it, and cancer as well by Dr. Montoya. That can be associated to sclerodermia that also produces this tiredness. Infections, acute infections, but also chronic infections, uh, like TB, for example. And also, the patient that has scleroderma has other diseases that are also autoimmune that can also produce this tiredness, like thyroid or myasthenia gravis. All of that has to be kept in mind about tiredness associated to the disease. This asthenia, it's multifactorial. So in other words, it is not due to just one factor, but to many, and it's very heterogeneous depending on each person. This is going to affect the person in one way. It's going to be described in a different way. What do we find in those special libraries where physicians look for information to tend to our patients as best as possible? What do we find there? It's it's not that there is a lot of literature. There's reviews, there's some about quality of life of fatigue, and about the function of the hand disease associated to fatigue. But in general terms, strokes, general strokes, let's say between 7 and 45% of the population in general that do not have a disease refer fatigue or being tired. 98% chronic disease, autoimmune disease, have asthenia. The one that is known more is lupus erythematosus, LES. And in this revision last year from the United States, this is a beautiful study because it is related to the difficulties or the affectations of the hand, or arthritis or tendinous retractions, and the limitations also due to ulcers, carcinosis, or the toughening of the skin. As Dr. Castellar has already mentioned, it is very important to keep the hands as functional as much movement. And it has also been proposed that there be a score to differentiate the different types of asthenia that I have commented. So here you can see if it's associated to the treatment drum, or if there are 5 or 9 symptoms out of the 9 that include in this score, maintain through 2 weeks in a row. That gives us an indication that it can be associated to the disease. What more information? We have a systematic review, 43 papers that bring together a series of characteristics, and they are scientific. The prevalence of the disease is most prevalent than asthenia is more prevalent in the general population and in persons that have cancer in remission. On the other hand, the prevalence of the patients that have sclerodermia is similar to those patients that have cancer, but that are receiving active treatment at that moment. On the other hand, it is less, in this case, with oncological patients who are in the terminal stage. They're receiving palliative care, and the prevalence rheumatoid arthritis, ankylosing spondylitis, or lupus. And what do we know about the treatments that we have at hand? And if they do something for this asthenia. There's very little experience. The trials or the studies are very small, very few patients. Tocilizumab, there's a trial with 51 patients, and they considered other items, other aspects, but in terms of fatigues, it did not improve. And that draws our attention a little bit because of another matter that I will explain. Suspending corticosteroids has been seen in a very small series. Tiredness does not improve. The supplements with thyroxine hormones in the patients that have hypothyroidism, it seems that they did not improve. This is a small series, 33 patients, alternative therapies. And once again, I say this and I say this very cautiously because there are many. And these are not broad studies, very few patients, but they improved in the perception of the quality of life of the patients. The only thing that has been demonstrated that improves the quality of life and the reduction of this asthenia is exercise, physical activity. In this regard, there's 63 patients with an active life with 363 patients that had inactive life. So it's 389 versus 363, the ones that had physical activity like walking, at swimming, and some jogging. There was an improvement in terms of the perception of asthenia with a median time of dedication a week of about 4 hours, 4.5 hours a week. Now, what factors are associated to asthenia and vice versa? Well, among the main factors, we have sleep alterations. Sleep alterations, they affect work. It's going to have an effect on the work capacity of the patient or disability. It's been seen that the patients that have uh, low type, they have lower visual analogical scales, those scores that we do. If we tell them from 0 to 10 in our office, what number do you reflects the degree of asthenia that you have? Well, in this case, we see that the patients that have analogical scales that are the highest, and then there's the quality of life is also affected. We have several quality scores that we give them in our office to quantify this. What has been seen that the patients that have higher scores in these questionnaires have less visits to the doctor because they go less because their asthenia is greater. There are also social demographic factors associated: age between 40-49 years of age women. They also have other comorbidities like diabetes. Of course, this has already been previously mentioned, and also the people that have scleroderma, that have a greater or lung affectation, gastrointestinal involvement, they have more asthenia. Also, when the analysis, this globular sedimentation rate is also higher, the joint affectation, and the patients that have an antibody profile that have the RNPs, they also have levels of tiredness that are higher. Pain, of course, that has an effect in um, fatigue or asthenia. Is one of the greater predictors of asthenia in the patients. Now, what causes pain? What causes pain? This is very complex, but I do want to set some things clear. It affects the central nervous system. the sleep and circadian rhythm. In other words, we have the sleeping cycle depending on the degree of light that we perceive, and it regulates a gland that we have back here. It's the epiphysis. And then the degree of inflammation. Now, I will speak a little bit about this. And then the vagus nerve is another one of the large nerves that innervates the lungs, the gut, and there are also alterations at a vascular level. There's a reduction of the blood flow. This has already been explained here by Dr. Vasquez. And stress also increases asthenia. And stress is a factor. Chronic sustained stress is a great effect in asthenia and metabolism as well. So these are strokes or just some comments about these different aspects very broadly, because I do not have enough time, but I did have to mention. What is that word? Well, I want you to keep this. These are proteins, very small proteins, but they help the cells to communicate among themselves. So these are the letters, if you will, of the language that exists among the cells. And in these letters, there are some. These as IL-6, IL-1 beta, IL-1A, interferon gamma, TNF alpha, that have the faculty of being pro-inflammatory. They increase inflammation. And all of these cytokines create a microenvironment of microinflammation that can affect, can alter behavior, mood. They can reduce pain through the threshold from which we feel pain, sleep, and motivation. And which is, if you will, we call them the signaling pathways. These are the ways. Once we have these letters, they go into the cells. Each one of them is going to have a different language. And all of these languages at the end, what they do, they still promote this inflammation even more. These changes favor the fact that we have this feeling of tiredness or fatigue, metabolism. We all need gasoline, the diesel, the fuel, solar energy, now that we're in climate change times. But what is that called in humans? They are called nutrients, fats, carbohydrates, lipids. They provide nutrients in the cell, then this is going to be transformed in ATP. Well, we know that scleroderma has an alteration of these mechanisms that produce energy that are mainly produced in a part of the cell that is called mitochondria. And all of that then helps to extend, perpetuate this condition of inflammation. They activate the inflammasome, these languages, the circadian rhythm. Chronic insomnia, we know, is associated now to the development of autoimmune diseases. Up to 88% of the patients that have chronic pain have sleep alterations. In other words, the loss of sleep also increases cytokines that I have mentioned that are pro-inflammatory. It's like a nightmare. It's a loop. And all of this has been scientifically proven in models with mice and humans. What we that is segregated by the anti-inflammatory effect. And it has been seen in experimental models and in humans that can help. As I have told you, chronic stress is poison for the body and particularly for autoimmune system. So we have these suprarenal glands, these little hats that we have over the kidney. They release natural corticosteroids. I can explain in detail, but what I can tell you is that autoimmune disease and sclerodermia, there's an axis between the central nervous system and the endocrine axis. There is an alteration with a microclimate favors the inflammation. The nervous system also has other letters, another language, let's call it. They are called neurotransmitters. The ones activate and the others inhibit. Well, then what happens with these diseases? There's a lack of balance. There's an alteration of the balance of the neurotransmitters. And all this lack of balance, then again, also produces alterations on motive, on sleepiness, on sleep or being awake, on the cognitive processes, staying awake, insomnia, anxiety, and lastly, energy. Well, Lastly, and for me, the most important thing out of all of this, can I do something as a patient so I can reduce my tiredness, my fatigue? Yes, you can. First of all, the calendar has to be adjusted to how I am and the degree of affectation. Keep an organized life, orderly. If I have a wedding, well, I have a wedding, but if not, I should try to maintain the same sleeping schedules or waking up schedules. I just can't go to sleep from just watching TV and listening to music at a high volume and then going into bed. There has to be a whole process of hygiene, like sleeping appropriately. If I have reflux, I do the appropriate. If I do not, eh, I control all of these aspects. Melatonin also helped me under the supervision of a physician. And as Dr. Castellar also commented, exercise, but it has to be adapted to my characteristics and situation. If I've never done exercise in my life, I cannot to become an athlete. I have to adapt. And then physiotherapy, as she was saying, this is super important. Of course, physiotherapy, I have to learn it and then I have to do it at home. And of course, stress management and psychotherapy, relaxation techniques are going to do well, and do not stop your social life. I congratulate all of the association. I know the Spanish Association of Sclerodermia, the initiatives Coffee with Sclerodermia that are organized in almost all of the cities in Spain, where people that have sclerodermia come together in a pleasant environment, promoting exercise with the second Nordic March. And of course, I want to thank all of the work you do from the associations. And lastly, I want to thank you for this invitation and for listening to me. Thank you very much. Thank you, doctor. Thank you, doctor. Once again, thank you. Your presentation is excellent, very educational. And now I will pose the questions that we have received to our email and the ones that have been added on the chat. So the next question is, what is your opinion about 12 or 16 hours? Does that help? Right now, well, there's a fad of fasting. And of course, I believe that a patient that has scleroderma, I would not recommend to start this. I would recommend that they should be in communication with their doctor, with their internist, with a nutriologist, of evaluation of the patient and design a diet that's specific to the characteristics and the needs. This is a topic that I like very much. I love speaking about microbiota. We know much more, but not everybody can have access to that type of testing. Now, to say that I would recommend intermittent fasting without any supervision, I do not believe that that is a. Thank you very much, doctor. A very frequent question, walking every day, 15 minutes and taking vitamin supplements, is that enough to have energy or is anything else needed as a complement? Sometimes it's enough, sometimes it's not. There are people that do benefit, but then there are people, like I have said, there are other factors that have an effect in asthenia, certain make this tiredness more rebellious. It all adds on. If I walk every day, first of all, walking is good if you have a place where you can walk. If maybe I cannot go out because of the weather, I can walk at home. And if not, wear comfortable footwear, go out into the street and walk, not just a window shop. Go out with nature or go down a long avenue. I go out for a walk. If I get tired, I find a place where I can sit. Vitamin supplements, that was the only question, the other question. Well, it depends. It depends because there are people that have an important digestive affectation that they are going to need vitamin supplements, vitamin B12, vitamin B. But once again, this has to be validated. You just don't take vitamins just for the sake of taking it, because vitamins, some of the vitamins are toxic, some are cleared through the urine. If are liposoluble vitamins, and they can produce toxicity to the body. So we cannot just take vitamins just for the sake of taking vitamins. Thank you very much, doctor. What are the suggestions for insomnia? Suggestion for insomnia. Well, first of all, good hygiene. Prepare the fact that you're going to sleep. If you're going to sleep, dim it, be in an appropriate environment half an hour before. There are infusions, for example, valeriana, the those soothing drops that you can take an infusion, or if I have reflux, I will take it before. Otherwise, then this will be annoying and I will have reflux. The appropriate light, low intensity. I have to bring down the volumes. I get into bed. And if I want, I can read a little bit. If the cell phone is on, it's preferable not to use it before, but if I'm going to dim it for night, because the contrast comes down, I will receive less excitation. There are apps that I can bring down that are special for people that have difficulty in sleeping. And those are soft sounds like water, like wind, or things that can help us. And then, of course, there are people that are going to need therapeutical assistance. The lightest thing are the infusions, melatonin, and then after that, then depending and always under the medical supervision, there are people that are going to need, evidently speaking, other things. But you have to be prepared. You just can't say, I'm going to bed now and not have this habit. But at least 2 hours before going to sleep, more so in sclerodermia because I might have reflux. So I have to, that for reflux, if you don't know, the head side of the bed is higher. It's not a double pillow. The whole bed must be in an inclined position to avoid reflux, and not eat abundantly, particularly certain food. So I am not uncomfortable if I use oxygen supplement. Everything must be prepared. Everything must be prepared for my night rest. Thank you, doctor. In regards to this question, the use of melatonin, is it recommended for insomnia? There are people that use it. As I have said, it's a hormone, a natural hormone. We produce it in our hypophysis. It segregates it in the night as the light goes down. The hypophysis starts segregating. What happens is that the same thing that happens to people that have jet lag. They travel, the pilots, the stewardesses, they this is known. This was known because there were studies done with people that continuously changed their circadian cycle. And then there's another hormone that has an influence, cortisol, the suprarenal glands, these little parts that are above the kidneys. They don't segregate the same amount of cortisol throughout the day. But when we are going to get up in the morning, they have a maximum peak to activate us. So then we also know that there are alterations in the patients that have autoimmune disease, like among them sclerodermia, that also alters the circadian cycle. That is also altered because of the corticoids in the treatment. So melatonin can be a good ally. I prefer melatonin for the patients than benzodiazepine. So that is a hypnotic medication, but always under medical supervision, because out in the market, they sell melatonin that are not the appropriate one. It has to be melatonin that are approved, and they have to be safe by the given medical association, by the supplements or drug agencies. The next question is, a vegetarian diet, does it improve asthenia? In nutrition, we could speak for hours. I'm not an expert. I am passionate. I think in sclerodermia, there's much work to be done there. But unfortunately, there's cure me, but the healthy eating is going to help me feel better, more so in a digestive tract that has difficulty many times, even for the movements, the esophagus particularly, but there are patients that also have bowel and there's bacterial overgrowth. The microbiota that is inside is multiplied. Now we know that in this microbiota, not well, there are many families of bacteria, and each family of the bacteria is going to have a function, a different function. So we have to make a lot of progress because very likely the patients that have scleroderma need the prebiotics or probiotics, but not just any. All right, not just any. So then what I would say, particularly, my advice is all of these services, the public health systems do not have a severe affectation. They don't do them. But if you can go to a nutriologist that is specialized in the topic, because the problem here is that a person that has scleroderma needs protein, there's muscle mass loss. So if I become a vegetarian or a vegan, then I have to know how to complement or supplement the or from fish. That is why when people say I want to do this and that, when one has chronic disease, one must be very careful, always be accompanied by a good professional. It seems that I'm repeating myself, but this is important. There's a lot of involvement here. And unfortunately, in the world, there are things that are not good and people take advantage. So one has to know that the associations play an important role because they know professionals that you can trust on rely and the nutriologist, I think, is fundamental in managing the patients that have scleroderma. Thank you very much, doctor. The other question that I have, I want to know if it's advisable to has seen Dr. Casillas. I don't think that there is exercise in limits, never in the extreme. Exercise, you should do exercise. What type of exercise? That you abide by that physical activity, Qigong, Tai Chi, all of the Oriental arts. uh, They're millennial for centuries. They have a spiritual components. I was speaking to a psychologist from Spain that's an expert in Qigong, and Qigong has a spiritual part, but to this day, the government, the Chinese government allows it because people that practice Qigong have a better quality of life and they live longer. So doing a physical activity, if there's a position that hurts, that is not annoying, let's say, but causes intense pain, I won't do that position or I will do it softer. But I think that these are arts that do well because the inner part works, meditation and spirituality. And that is why I believe they contribute. Excellent explanation. Doctor, I have another question. This is about, is there food to improve inflammation? In this regard, we would have to personalize. I've had patients that those healthy food did not do well with them. People complained of headache, for example, lettuce salad, that's very healthy. People couldn't tolerate it. So, evidently speaking, all of the green leaves, vegetables, broccoli, that's healthy. Now, if I notice that I'm eating asparagus and it doesn't sit well with me, and I know that's it. Every time I have that, I don't feel well. Then even though they tell me that's not good for me, complain to complain. And when people tell you this doesn't sit well with me, then we, the physicians, many times there's so bacterial overgrowth leads to the fact that the epithelium, the inner part of the gut that is in contact with the nutrients that I have commented, is altered. There's lactose intolerance, fructose intolerance. There are people that say, I eat a lot of fruit, but I don't feel well. There are fruits that have a great amount of fructose. So I believe that for me, a good nutritional evaluation, the we should measure vitamins group B, D. There can be deficits of vitamin C depending on the diet. Those diets that are strict at the end, they're still dangerous because they're going to remove a series of supplements that we need. So there has to be supervision to say, well, you need to take this supplement because you cannot just take this whole series of food. You have to receive it from elsewhere. So we are clear that diets have to be done under supervision. Nutritionist specialist. I have another question. What does it mean to maintain muscular pain always? Thank you, doctor. We thank Dr. Paloma Garcia de la Peña for their time and dedication in this very interesting topic for the patients and families who sometimes don't understand what is happening. I now yield the floor to Venezuela, who will moderate the next presentation.
Hello, everyone. Thank you very much, Carmen. Good afternoon, everyone. The next presentation will be presented by Mexico recent research in Scleroderma. Representative of the and the introduction of Dr. Tatiana Rodriguez will be made by the Mexican Society for Scleroderma. It's my pleasure to introduce Dr. Tatiana Rodriguez Reina, who is a medical doctor with graduate studies in internal medicine and rheumatological sciences. She's a medical sciences researcher at the Immunology and Rheumatology Department, National Medical Sciences and Nutrition in Mexico City. She has published journals on immunology and rheumatology. You have the floor, Dr. Rodriguez. Good morning, good afternoon, everyone. Good afternoon. It's a pleasure to be here with you. I want to thank the organizers for this invitation to participate with this presentation. These are my disclosures. I'm speaker and scientific advisor for companies that did not participate in the preparation of this talk. I have limitation of topics due to Scleroderma Foundation policies. And I need to say that not all treatments I'm going to mention are available in all countries. Our recommendation is that you contact your doctor and ask whether a certain treatment is appropriate for each patient. Scleroderma is systemic autoimmune disease of the connective tissue. It's quite unusual, much more common among females, and the treatment response is quite difficult due to multiple factors, due to the different manifestations and stages of disease and the various complications in different patients. We know that the major causes of mortality are interstitial lung disease, which is pulmonary fibrosis. That is why current treatments have focused on the lungs, because this is an important site of complications in these patients. Pulmonary hypertension, cardiac complications, and kidney involvement. I'm going to address a little bit of each one of these. Speak about treatment. I would like to say that this is a complex disease where there is a component of autoimmunity, that is to say, attacking one's the self cells, a component of chronic inflammation, and a component of blood vessel and skin damage. Has physical characteristics. these are some of the ACR EULAR criteria to determine the patient's score. We divide the disease into two large groups: the limited disease or without scleroderma, with or Scleroderma with involvement in the face, arms, or legs, and diffuse disease, which is the one affecting much more of the skin. In this case, the skin is the window to the disease. The more the skin is affected. As physicians, it is important that every time that we see a patient, we determine what is the degree of skin involvement using all of these scores, like the modified Rodden score, that helps us rate the skin at every visit. And this allows us to determine whether the disease is progressing or not. And based on this, we can prescribe treatment. There are two large groups of the disease. The limited cutaneous disease where not much skin involvement, and there is involvement of inner organs that appear late. And there is also diffuse disease or diffuse cutaneous disease that in the early stages of disease, it affects not only the skin, but also inner organs. This is the stage that I have shown with the red circle. There may be vascular complications, heart, kidney, lung. This is when we have the treatment in order to prevent long-term damage. We know this is a systemic disease. This is data of our series in Mexico. These are patients who have organ joint damage is more common in patients with diffuse disease than with the limited disease. But those with limited disease are not free of having inner organ damage. About treatment, I'm going to share with you what we have learned in recent years. I will use the EULAR recommendations. As you can see here, these recommendations were published in 2017, so they are not completely updated. They were based on literature review and considering experts' opinion, and not all of them were based on large clinical trials. First of all, Raynaud phenomenon, as all of you know, it's the phenomenon characterized by vasoconstriction. There is, so patients have impaired blood supply in certain parts of the body. Treatment of Raynaud's is vasodilators as first line, and phosphodiesterase and others. There are other treatments like iloprost, which is a prostaglandin analog, and IV preparations also are available, or oral preparations. Some of them are available in all countries, some not. There are small trials with other drugs like antidepressants such as fluoxetine that are thought to play a role in the treatment of Raynaud's. Then we have the ulcers and scars, some of which also have a poor blood supply component. In the case of finger ulcers, vasodilators are used, but they represent a more severe but if there are complications beyond the Raynaud's, we use iloprost, which is a much more potent vasodilator. There are studies supporting the use of PD5 inhibitors like sildenafil, tadalafil, baldanafil, and others like bosentan and matisentan, and this kind of treatments that may reduce the appearance of ulcers. There are others that are not included in these recommendations, like angiotensin receptor antagonists, like losartan, valsartan, that are used to treat, for instance, high blood pressure. Topical nitrates or vasodilators that are topical as ointment or patches, and other prostaglandin analogs like epoprostenol. There is another very important vascular complication, which is pulmonary arterial hypertension, PAH. This means that the small blood vessels in the lungs are constricted, and not only that, but they become thicker, so there is irrigation. that may lead patients to having important cardiopulmonary complications and even death. So it is very important to do research around this kind of treatments. Background treatment, according to EULAR, include endothelin receptor antagonists like bosentan, macitentan, ambrisentan, PDE5 inhibitors like sildenafil, vardenafil, tadalafil. They are the same vasodilators that are used for Raynaud and ulcers, but they may also be used as vasodilators for patients with PAH. Also, prostaglandin analogs and others that are being used or under study recently, like riociguat, which was included recently, and methyl bardoxolone, which is quite experimental. Novelties in the treatment of a PAH is combination therapy. This is very important. As for the treatment of PAH, say that it is much better for patients to get combination therapy with the 2 or even 3 vasodilators from different groups. This is like a a PDE5 inhibitor, and this may be combined with an endothelin inhibitor. That is to say, drugs from different groups. We may combine 2 or even 3. If you take a look at the most recent clinical trials, you will see that they are not testing a single drug versus a placebo, but they use patients with the standard therapy, and they want to see if a second or third drug from a different drug class is useful. Studies are becoming more and more ambitious. They try to see a benefit of adding a third drug, whether survival improves or only parameters like the 6-minute walk test, respiratory parameters like oxygen saturation. They are also looking at improving survival. Then we have the skin treatment. I would like to explain something. In a patient with systemic sclerosis, I'm sure that many of you know this, there are several stages. Initially, the hands and the rest of the skin may be edematous, may be puffy. Then there is induration, that is to say, it becomes hard. And after many years, patients which the skin sort of is thinned. In fact, the skin becomes thinner, more delicate. Ulcers or bruises may appear more easily. So when we speak about skin treatment in systemic sclerosis, we're going to focus on the edematous and induration stages. For patients in the atrophic stage, these are patients who have had the disease for many years, disease or in whom the skin does not change much. Well, these patients usually do not need aggressive treatment for the skin and the lungs. However, patients who are in the early stages, in the edematous or indurated stage, we need to try to treat them. EULAR recommendations for skin treatment, and the skin and the lungs go together here, because it has been seen that when the skin status worsens, this is when the lungs start have pulmonary fibrosis and damage starts progressing. So the skin and the lungs share these indications. There are clinical trials that support the use of cyclophosphamide to treat the skin and the lungs. This is based on the Scleroderma lung studies 1 and 2. These are two classical trials in which cyclophosphamide was used to treat the skin, but it was seen that it benefits the lungs as well. Methotrexate is also recommended based on two clinical trials as a marginal response. This is in the recommendations, but personally, I think that methotrexate for patients with systemic sclerosis has a marginal. In these studies, methotrexate was used, and the improvement was 5 points in the Rodnan score. If the score ranges from 0 to 51, patients with severe skin disease have a score of 40 to 45. Decreasing 5 points in the score is very little, so I think that methotrexate is not the right treatment. The guidelines didn't include mycophenolate mofetil or MMF, but it has proven efficacy in the skin and lungs in Scleroderma lung study too. MMF was compared versus cyclophosphamide. These were 5 large trials, including 5 groups of patients. MFCF was found to be as effective as cyclophosphamide to treat patients and to stabilize. The skin improved as well, therefore is used as a standard treatment for patients with the skin and pulmonary manifestations of systemic sclerosis. Cyclophosphamide continues to be used, but it is a bit more toxic than MMF. Administration is IV, so MMF is easier to use, less toxic. That's why it is used more. In sites where MMF is not available or it is very expensive, one may use cyclophosphamide. Other treatments that have been used recently include rituximab. Rituximab is a drug that we use quite often for rheumatoid arthritis and SLE. It was approved many years ago. It has proven to be effective in patients with systemic sclerosis. It has been seen in large, small clinical trials, and there is a meta-analysis that included many trials with many patients. It saw that rituximab may be useful to treat the skin and the lungs, but this has to be considered with a caveat. We use it in refractory cases of patients with systemic sclerosis that cannot receive another treatment or are refractory to other treatments like MMF or cyclophosphamide. I would like to mention some of the common treatments. Lenabazum is an cannabinoid receptor agonist. It was designed to see the antifibrotic effect. There are 2 small clinical trials, a phase 2 trial and a phase 3 trial that are underway right now that have shown that this drug has antifibrotic effects. This does not mean that cannabinoids have an effect on systemic sclerosis. This was a drug designed specifically for its effects on the receptor as an antifibrotic. They don't mention any other effects. Regarding patients with late diffuse scleroderma, no specific treatment is warranted. Let me address the drugs that have to do specifically with the lungs with interstitial lung disease, ILD. Tocilizumab is frequently used for RA and systemic vasculitis. Its efficacy and safety has been proven in these 2 conditions. In the case of systemic sclerosis, there are 2 important trials. The FASCINATE trial, a phase 2 trial, showed that this was a safe and effective treatment in patients with systemic sclerosis, and the FOCUS phase 3 trial that showed that this drug may stabilize skin damage and may improve the lungs. Based on this, the FDA approved it for the treatment of interstitial lung disease in these patients, but we thought it could be beneficial. There is another treatment that is being tried or tested. Pirfenidone is an antifibrotic treatment used for other types of pulmonary fibrosis and for liver fibrosis. Pirfenidone was used in a phase 2 trial, Lotus, that proved that it was systemic sclerosis. A phase 3 scleroderma lung study is underway using pirfenidone. This is a drug that may be combined with MMF and other immunosuppressants, unlike other drugs. Another novelty is nintedanib. Nintedanib is a drug that is used to treat other forms of pulmonary fibrosis. Studies have done in recent years to test it for systemic sclerosis. 1 or 2 years ago, the FDA approved it to delay progression of ILD in cases of systemic sclerosis. An advantage of this drug is that it is antifibrotic, and together with pirfenidone, It may, as pirfenidone, it may be used together with immunosuppressants. We have treatment that may be used together with standard treatment for systemic sclerosis that could help improve lung function and ILD in these patients. Then we have the treatment for other manifestations. For instance, for scleroderma-related renal crisis, this consists of abrupt increase of blood pressure in patients with systemic sclerosis. This is treated with ACE inhibitors that many of you are familiar with, like enalapril, captopril, etc. And this is specific treatment. It is not appropriate for prevention. This is a treatment only when this complication has occurred. Regarding the GI tract, there are many frequent alterations. There are no clinical trials, only the EULAR recommendations that state that like omeprazole, pantoprazole, when there is GERD, prokinetics may be prescribed when the patient cannot swallow properly, cannot swallow the food, and one may prescribe antibiotics when patients have the frequent diarrheas that Dr. Paloma mentioned a while ago due to bacteria. Other manifestations like the cardiac complications, calcinosis, inflammatory myopathy, and arthritis are not addressed by the EULAR recommendations, but we use different anti-inflammatory and immunosuppressor agents to treat them and according to the organ involvement. Non-pharmacologic treatment is very important. This is an important support through physical therapy. Physical therapy, nutritional therapy, and psychological therapy is very important in the treatment of these patients. And this is for the reasons that you already know. This is a systemic disease, warrants non-pharmacologic therapy from the very beginning of the disease. With this, I will end my presentation, hoping that you enjoyed it. I want to thank the organizers. This is my email in case you have any questions. I'm available to entertain questions that you may have. Thank you very much, Tatiana, for a very Let me read the questions that we have received in the chat and via email. The COVID vaccine represented an important advance for the study of pulmonary fibrosis. Can this help create a vaccine against scleroderma? What do you think? Let me make sure I understood the question. The COVID vaccine can you repeat the question for me? The COVID vaccine helped the study of pulmonary fibrosis. Can this help create a vaccine against scleroderma? The COVID vaccine did not really represent any progress for pulmonary fibrosis. What it did was to reduce the severity of COVID cases. Patients who get COVID and develop severe COVID, well, in fact, they develop very severe pneumonia, and patients may end up having lung damage. And this lung damage may be caused by fibrosis. So, but I don't think that we can extrapolate this to thinking about a vaccine against systemic sclerosis, because it's an autoimmune disease in which our own cells recognize our own tissue as foreign, and they think they need to attack it. That's why we see tissue damage, which causes that this vaccine will help find a treatment for systemic sclerosis. Do you think that we will soon have a drug that will correct the immune system so that there is to prevent autoimmune disease? Well, any drug as such is complicated. I would rather think about other treatments that serve the purpose of sort of resetting the immune system like we do with our computers. These treatments are treatments that I cannot discuss right now due to the policies of the National Scleroderma Foundation. But the purpose of these treatments is to sort of reset the immune setting. Drugs aimed at reverting these errors of the immune system. We don't have them so far, and as far as I know, they are not under development. But we do have antifibrotics and immunosuppressors that intend to fight inflammation and fibrosis. In this disease, fibrosis and inflammation are what cause the damage. These are drugs that prevent damage. As a result of this, the disease cannot progress or have any other consequences. How far are we from finding a cure for scleroderma? I really don't know. I would say that is a very difficult question. I don't know how close or how far we are. I would say that probably in the past 5 years, the advances in the treatment of systemic sclerosis have been very important. In the past 5 years, it seems to me that the rheumatology community and the scientific community have turned towards systemic scleroderma, or at times information is coming from different specialties. That's why it is important to conduct and in a multidisciplinary ways. Antifibrotics like perferonate, which is a drug involved, but perferonate comes from antifibrotics and it blocks vascular damage pathways, so it has been used in cancer. TKIs are a group of drugs that are used in various neoplasias. So this multidisciplinary research has led to drugs from other disciplines being prescribed for new indications. This has been a very enriching interaction. We have seen important progress in recent years. I, I hope that we are closer and closer to finding a cure. Besides rifaximin, what else can we use to treat GI involvement? This is a very important question. I didn't elaborate on the GI tract because there are not much clinical trials. But in systemic sclerosis, the GI tract may be involved from the mouth to the anus. This may involve a dry mouth in the mouth because of lip stiffness. These are very important limitations for patients. So for the GI tract, things that can help the patient open or close their mouth. They need to visit the dentist. Hygiene products for the dry mouth that are important because they help assist with the GI enzymes. Saliva contains many enzymes. So if the patient has reflux problems or esophageal problems, then we prescribe prokinetics, treatments that help with the stomach or gastro, that food can reach the bowel properly. Antacids to prevent acid from burning the stomach. Rifaximin is an antibiotic that prevents bacterial overgrowth. Rifaximin may work as well as other antibiotics. Rifaximin is a good antibiotic, but there are many patients who tell me they cannot purchase it. Others, metronidazole, tetracycline, that serve the same role, and at times we switch from one to another one if when one is not working. So there are antibiotic options and several drugs that may help the patients have a better quality of life, to reduce gas, like digestive enzymes. They are prescribed by gastroenterologists, like dimethicone, simethicone, that reduce gases. They improve quality of life of patients. To treat pain, if there is spasmodic pain, we may use antispasmodics like trimebutrin, butyl hyoscine, and these drugs that other physicians may recommend. There are many drugs that may be used for different purposes. Any drug for calcinosis that you may recommend? That represents a challenge, calcinosis. There are some studies where it has been seen that the patients improve using calcium channel blockers like verapamil. Contact your doctor if you think that a calcium channel blocker or calcium antagonist may work. A study showed that certain drugs that are used to treat osteoporosis, like alendronic acid or risedronic acid, risedronate, or zoledronic acid, there is a study showing that some of these drugs may represent an option. This was found by chance. They had a group of patients with osteoporosis that started to be treated. Some of the patients treated with alendronic or zoledronic acid, they say, you're treating my osteoporosis, but my calcinosis is improving. My calcinosis is being reduced in size. So this is another treatment that you may want to discuss with your doctor. Other treatments that have been used experimentally or for investigational purposes are those that include lithotripsy. As the lithotripsy is used to treat kidney stones in patients. There are patients with calcinosis who have been treated with lithotripsy. Undoubtedly, if there is infected calcinosis, it warrants drainage, and you need to prescribe an antibiotic. If there is calcinosis at a pressure site, like in the buttocks, this is quite bothersome, so surgery is possible if there is appropriate skin quality. So make sure you discuss this with your physician. There are several diagnoses anywhere in the world. There is no standard treatment. Everything has been experimental, anecdotal only, and based on case reports. Another question is why MMF is recommended for patients who have been transplanted, and rheumatologists prescribe it to patients with scleroderma. Yes, as I said before, the treatment of autoimmune diseases has benefited from the multidisciplinary treatments used in other specialties in medicine. MMF, cyclophosphamide, tacrolimus, cyclosporin are all drugs that have been used to inhibit the immune response in patients who have undergone a kidney or a liver transplant. They are immunosuppressors. So in the case of autoimmune diseases, and none of them, because sclerosis are autoimmune diseases. In this disease, the immune system is working excessively. It is sending the wrong signals. It is telling the body that it has to produce inflammations, attack organs, cause joint inflammation, that the skin needs to be thickened, but that is due to an error in the immune system that is overactivated. That's why we use immunosuppressors like MMF so that they can send the signal that not so much inflammation is required because there is overactivity of the immune system. So these drugs are used to tell the body, don't overdo it. Try to be quiet because you are working too hard. Drugs are used so that transplanted patients do not reject the organ, the transplanted organ. Most of the times, the patients have received an organ from a relative, not from their immune system may attack those organs. So give these drugs to send the signal that the organs that have been transplanted are not attacked. There is a very interesting question. Well, all of them are interesting. Does this drug that you mentioned, nintedanib, sclerosis? Nintedanib does not cure systemic sclerosis. While it has been seen that nintedanib slows down lung damage. It has been used in patients with pulmonary fibrosis, and scleroderma does not worsen thanks to nintedanib. So far, we have not seen that nintedanib remove or cure fibrosis or makes it disappear, but it contribute to slow it down and not progress. This is particularly due to the type of patients that we are treating properly. If we treated patients with earlier disease, maybe we will see that fibrosis does not occur or it stops at the early stages. But this is something that we will surely see in later trials. We will see this when we start treating patients with earlier disease to see whether it can prevent further damage. Last question. There are many more, but this is the last one that we are going to read. What is the drug that can help decrease CRP? CRP, C-reactive protein, is a marker of inflammation. Tocilizumab is a drug targeted to IL-6 receptor. Tocilizumab Ropembra brand, it is targeted to IL-6, which promotes the production of CRP. So tocilizumab has this specific action. There are other immunosuppressors that also may decrease inflammation and CRP. But tocilizumab is the only one that clearly does this directly. Although others also help decrease CRP and other inflammation markers. CRP is not the only one. There are decreased by other immunosuppressants. Thank you very much, Doctor. We thank Dr. Tatiana Rodriguez. Thank you for this interesting presentation.
Monica, the floor is yours. Thank you very much. So now it's farewell from this second event on Scleroderma for Spanish speakers. And the beautiful project that we started a couple of months ago has concluded today with the gratification of having fulfilled this dream, having Teresa Munoz from the Spanish Association, Tina Ampudia from the Mexican Association of Support and Battle Against Sclerodermia, Marta Mayorga from the Colombian Association of Scleroderma, Ana Salva from Sclerosalud, and the Civil Association from Argentina, Monica Ramirez from the National Association. It truly has been inspiring to see the commitment of so many people from different places in the world who have demonstrated solidarity and a sense of sensitivity to support all of the patients that suffer this condition, to the families, to the health providers. Each one of the presentations we had today has been selected thinking on the community of scleroderma, educating the patients, the community, and the family who sometimes feel abandoned and alone with a condition that they tell us is chronic, is degenerative, and has no cure. It is true that there is no cure for scleroderma, but currently there are treatments, targeted treatments to control inflammation, fibrosis, and the vasculopathy that are characteristics of this pathology, as well as to prevent the progression of the disease and the deformities. So treatment must be started as early. The factor is to understand the symptoms. And so we invite the members of the organizations to become educated of this disease, learn that there are options for treatments, and let's not be overcome by pain and the changes that we are forced to make in our life because of this condition. When I was diagnosed with scleroderma 13 years, but as many other patients, the struggle started to look for the second and the third medical opinion. And aside from other medical treatments, I was determined to continue living and to stay with my daughter, who was just a teenager. I had the good fortune and the blessing that I had my husband, my life partner, who is a loving person who accompanied me throughout this whole process. It is very important for the patients that have scleroderma to have the support from their family, a fundamental pillar in our lives, because it is them who are going to hear us out when we are weak or when we do not want to get up because we are in pain, or as one of the speakers said, when we don't have the energy. Our deep appreciation for our speakers today, to Dr. Argentina, Dr. Natalia Vasquez Canizares from the United States, Paloma Garcia de la Peña from Spain, and Dr. Tatiana Rodriguez from Mexico. Having speakers of this high profile has allowed the attendees to this event to acquire valuable knowledge in different topics, and we appreciate your time, their talent, because through their experience, they have provided us with guidelines to overcome the challenges that we face. The National Foundation of Sclerodermia and the other associations of sclerodermia in our continent and then Spain are the voice of thousands of patients that face this disease. Regretfully, sclerodermia does not distinguish between race, gender, or age because it affects children, teenagers, and adults. The prevalence of this disease is estimated at 250,000 or 300 people affected per million of inhabitants, according to the Spanish Federation of Rare Diseases. There in the world, there are about 2.5 million persons that have scleroderma. The impact of diagnosis is a strong one, but we must not just cross our arms waiting for the outcome to come. Scleroderma is going to act in different ways in different patients, and we must help the physician and not just be bystanders. Our commitment as patients must be that of giving visibility of our disease by speaking to the governors, the local governors, lobbying designation of funds cure for scleroderma. This is a teamwork. We would be like a sporting team. It's the work of the patient, the associations, the physicians, the researchers, the scientists, the pharmaceutical labs, and the health officials. We want to thank the moderators for this event who joined forces to speak about scleroderma. Lisbeth Ajon from Costa Rica, Veronica Flores from Ecuador, Elizabeth Gallardo from Peru, Daniela Gonzalez from Chile, and Soriche Alizama from Venezuela. And I would like to close with a famous quote from Confucius: education generates trust, trust generates hope, hope generates peace. Before we close, I want to thank our personnel behind the scenes who allowed us to hold this event. And now I would like to ask my colleagues to please last part to say farewell for the now. Teresa, we're going to miss you greatly. We hope to see you in the third event of Scleroderma 2023. Let's continue in this battle so that there is cure for scleroderma one day. Thank you very much.